Assalamu alaikum, everyone. I would like to welcome you today for another day of a series of webinars which are organized by Saudi Society for Blood Disorder. Today is the second day of the Peripheral Blood Morphology course, crash course. And today talk, Dr. Haytham Khougher will try to cover WBC morphology and hematological emergencies. So it will be over 1.5 hours, and please type your questions, comments on the Q&A section. Please be reminded that the webinar is recorded and will be available through SSBD social media accounts. Without any further ado, it's my great pleasure to introduce Dr. Haytham. Dr. Haytham is a hematopathologist at King Faisal Specialist Hospital in Riyadh. He was trained in MD Anderson, and we are looking forward to his talk. Please be reminded that this series of webinars are sponsored by a restricted fund from Acute. Without any further ado, Dr. Haytham, the mic is yours.
شكرا دكتور فراس. بسم الله الرحمن الرحيم. Can you see my slide?
Not yet. If you can share the screen.
Let me share the screen.
Okay.
Now?
It's clear now, but if you can put it in the presentation mode.
Okay. Clear now?
Yes.
طيب. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone. In this presentation, I will talk about the different non-malignant leukocytes disorder, in other hand, benign white blood cell disorders. So I try my best to summarize and make it simple for you. So let us start with the case number 1. This is peripheral blood smear from a 30-year-old female who came for general checkup. As you can see here, her laboratory data shows normal CBC, but let's identify the cells that's shown on this image. So these cells are neutrophil, and this is eosinophil, and this one basophil, and this one monocyte, and this one lymphocyte. So segmented neutrophil is the mature cells of the myeloid series that constitute 40% to 70% of the white blood cells, of course, in the peripheral blood. This is band cells. So band neutrophil is the immediate precursor of the segmented neutrophils, and it constitutes around 5 to 10% of the white blood cells in the peripheral blood during normal condition. This is monocytes, which looks larger than neutrophils and shows abundant gray or gray-blue cytoplasm that may contain vacuoles, as you can appreciate here. The chromatin is condensed, but is usually dense than that what you can see it in the neutrophils or lymphocytes. Eosinophil is characterized by coarse orange-red granules, uniform size, and is similar to a neutrophil in the diameter. And normally, the nucleus demonstrates condensed chromatin and nuclear segmentation with 2 and sometimes 3 nuclear loop. This is basophil, which is the least common circulating granulocyte. And this is unlike neutrophil, which shows 3-5 loop nucleus or loop. It typically has only 2 prominent nuclear loop and cytoplasmic with numerous dense purple basophilic granules, often obscuring the nuclear details. This is typical lymphocyte, which is slightly larger than normal RBCs with scant to moderate pale blue cytoplasm, round nuclear contour, mature chromatin, and inconspicuous nucleoli. This is large granular lymphocyte, which is medium to large cells with round nuclear or nucleus, dense chromatin, and no visible nucleoli. The cytoplasm is moderate to abundant, clear and lightly basophilic compared to the previous typical lymphocyte, and contain several coarse uneven distributed small eosinophilic granules. So this diagram shows how these cells maturation sequence. So we have common myeloid progenitor cells and common lymphoid progenitor cells. So common myeloid progenitor cells create three types of progenitors: granulocyte monocyte progenitors, which give rise to neutrophils and monocyte and macrophage. The second one is eosinophils basophils progenitor, which give rise to eosinophils and basophils, and megakaryocyte erythrocyte progenitors, which give rise to platelet and erythrocyte. On the other hand, there is common lymphoid progenitor, which gave rise to the lymphocyte, either B and T. So each of these divided and matures into cells known as blast, one for each cell line from where they divided and differentiated to different subtypes. These figures demonstrate the normal maturation sequence of neutrophil starting from myeloblast, which is the early stage of neutrophils. Then it matures or differentiate into promyelocyte, then myelocyte, after that metamyelocyte, and band neutrophils, and finally segmented mature neutrophils. So in the peripheral blood, usually you find segmented neutrophils and band neutrophils. Case 2. This peripheral blood smear is from a 50-year-old woman with septic shock. So here laboratory data shows white blood cells 15.6 and low red blood cells, low hemoglobin, and also low platelet. So she has, before going to detail, I just want you to recognize the abnormal finding just by looking up to the CBC and peripheral blood morphology. So based on the peripheral blood, based on the CBC result and peripheral blood smear, patient has abnormal count, as we said, high white blood cell count and low hemoglobin and platelet, along with some morphological changes in the neutrophil. Case 3, this peripheral blood smear is from a 30-year-old male presenting with systemic sclerosis. Again, before going to the details, based on the CBC and peripheral blood morphology, this patient has abnormal count, low white blood cells, along with abnormal neutrophils. So now let's first have an overview of the different white blood cell disorder classification. So we categorize these disorder into quantitative, where there is an alteration in the number, or qualitative, where there is morphological or functional alteration. Quantitative can be subdivided into two again, which are acquired, including reactive process or inherited, and malignant or clonal, which will be covered tomorrow. The acquired alteration usually described by an increase or decrease in the white blood cells. For qualitative alteration, it can be categorized into 3 conditions: morphologic abnormalities, or with normal morphology, and those with morphological changes. So each white blood cells we have, the neutrophil, eosinophils, basophils, monocyte, lymphocytes, may either have a qualitative or quantitative abnormalities. Many times, almost all cases show quantitative and qualitative abnormalities parallel together. To discuss the quantitative abnormalities, it is necessary to define the different reference ranges for the white blood cells count and for its subtype. It is also to remember that these reference ranges may vary in between laboratory because of different cell counting procedure, instrumentation used in the laboratories, method that used in the validation to establish this value. Also, different reference value may given to the different patient population. So this is the reference value that we followed in the King Faisal Specialist Hospital. And these are some related important terminology that we use it when we are dealing with quantitative white blood disorder. Leukocytosis, simply defined as leukocyte count above a normal range. Leukopenia, again, which is defined as having white blood cell count of less than a normal reference range. And pancytopenia, this term given when there is a decrease in all other different cell type also. So going back to the previous case to discuss it in detail. So this is peripheral blood smear, again from a 50 years old woman with septic shock. Her laboratory, as we said, it shows leukocytosis, and the differential shows mainly neutrophil that represent around 85%. So the leukocytosis is characterized by increased neutrophils, which we call it neutrophilia, which is increase in the neutrophils count above the reference range. And the 3 main causes of neutrophilia are infection, inflammation, and malignancy. Also, it either be pathologic or non-pathologic. In other hand, it can be result of primary causes like MPN or secondary causes like infection and others. Leukocytosis, as we said, it's characterized by increased neutrophil, of which many shows toxic changes. So the toxic changes include toxic granulation, which is mean granulation is more prominent than what it is typically observed or seen in the normal neutrophil. So this is normal neutrophil, and these 2 neutrophils showing increased granulation or toxic granulation. The second change is toxic vacuolation. Again, compare it with the normal. There is no vacuoles in the normal neutrophils. However, this cells or this neutrophil shows prominent vacuoles. The third changes is Dohly bodies. So basically, these are blue or gray, blue, round, elongated shape inclusions found at the periphery of the cytoplasm near the cell membrane. So either toxic granulation or Dohly body, if present in individual neutrophil in isolation, it will be sufficient to designate a neutrophil as a toxic. On the other hand, vacuolation can be due to either toxic changes or degeneration process. Therefore, the process of neutrophil with vacuolation as a sole finding should not be labeled as a toxic vacuoles, unless accompanied by toxic granules and or Dohly bodies. So leukocytosis in septic shock and other reactive condition may be so high as to mimic leukemia. Then it referred to as a leukemoid reaction, where there are an increase in the neutrophil in addition to some left shift. Infection, trauma like burn, underlying cancer, especially when they shows paraneoplastic reaction, and drug like GCSF may cause leukemoid reaction. Leukemoid reaction may be confused with the MPN, including CML, atypical CML, or even CNL, chronic neutrophilic leukemia. So how we can differentiate these? So in leukemoid reaction, neutrophils are dominant and usually shows toxic changes, toxic granulation and Dohly bodies. While in the CML, it shows some left shifted with the expansion of intermediate stage myelocyte and metamyelocyte. As we can see here, left shift, some immature myeloid precursor. In addition with basophilia and eosinophilia. Therefore, careful attention to cytological characteristic of the neutrophils, for example, toxic feature and presence of an accompanying left shift, as well as clinical and laboratory feature, for example, history of infection, trauma, drug is required to arrive at the correct interpretation of the peripheral blood smear. Case 3, this peripheral blood smear is from an 11-year-old girl presenting to the emergency room with wheezing, and she is diagnosed with asthma. So her CBC showed high white blood cell count, and as you can appreciate here, eosinophils. So her peripheral blood shows a lot of eosinophils because her differential or the leukocytosis is characterized by increased eosinophils. So this patient has eosinophilia, and eosinophilia can be primary or secondary. Primary, that's mean eosinophils are neoplastic, such as that absorbed with the MPN, or secondary, like that involved with the reactive process like infection, mainly with the parasite, or allergic reaction like asthma or atopic dermatitis. Eosinophilia also can be short-lived or prolonged. In most cases, short-lived eosinophilia is it mainly due to many of potential secondary causes. In cases of prolonged eosinophilia, especially at the high level, it is usually associated with the potentially primary eosinophilia disorder. A detailed clinical history and laboratory investigation is critical for appropriate management of patient with eosinophilia. A patient history and physical examination are important to determine the presence of any risk factor or sign to guide subsequent laboratory testing. Peripheral blood smear has limited utility to distinguish between reactive and neoplastic causes of eosinophilia. However, some mild dysplastic feature, including hypogranularity or hypersegmentation, more than 3 loops, and vacuolated cytoplasm, can also be seen in the reactive condition in limited. However, frequent or marked dysplasia especially when you have eosinophil with abnormal coarse granules like this one, that coupled with the dysplasia in the other cell lines or coupled with the blast, these finding favors a neoplastic process. Again, examination of the peripheral blood carefully, especially the tail of the smear and the edges of the smear, is very important to reveal it may show some parasites. If a clear reactive causes is not identified, further investigation, including a bone marrow biopsy, cytogenetics, and other molecular testing should be performed. Overall, eosinophilia is ineffective of a variety of processes and require a thorough investigation and clinical correlation. Case 4. So this the peripheral blood is from a 19-year-old male who complained of fatigue and fever. So his white blood cells is high with normal RBCs and hemoglobin and platelet count. Again, the leukocytosis is characterized by increased lymphocytes, and these lymphocytes, it's look little bit atypical if we compare it, and different if we compare it with the normal one. So lymphocytosis in general can be divided into those with reactive morphology and those without reactive alteration. Causes of the reactive morphology are usually viral infection like CMV, HIV, and herpes. Although other bacterial infection also may cause an increased lymphocyte, like syphilis. Example for non-reactive morphology would be whooping cough that caused by Portadella pertussis. And if you want to differentiate between the reactive lymphocyte from the other variant, the key distinguishing feature for of the reactive lymphocyte is their wide range of cellular size and shape, as you can appreciate in this picture, as well as a nuclear size, shape, and chromatin pattern. This is another picture for the reactive lymphocyte. So reactive lymphocyte usually have abundant cytoplasm, which is intensely basophilic, and sometimes shows cytoplasmic bleb formation. And this feature usually it reflects the immune process or immune stimulus that initiated by viral infection. In contrast, while lymphoma condition exhibit more monotonous population of abnormal lymphocytes. So for this case, further testing demonstrate positive monospot test that confirming infectious mononucleosis. Case 5, this peripheral blood smear is from a 35-year-old man with no significant past medical history, who presenting with headache and easy bruising. Laboratory data includes white blood cells shows low count, around 2, RBC and hemoglobin also reduced, and platelet shows thrombocytopenia, severe thrombocytopenia. So generally, patient has pancytopenia. So the leukemia here is characterized by the presence of these abnormal cells. So these cells, again, this is another picture for these abnormal cells. So basically, these are abnormal promyelocytes, which consider as a blast equivalent in the background of leukemia. And we want to compare these cells with the normal promyelocytes. So promyelocytes are round to oval cells that are generally slightly larger than the myeloblast. But the abnormal promyelocyte differ from the normal promyelocyte in several aspects. The abnormal promyelocyte nucleus is usually folded or bilobed, like here. This is another picture of bilobed cells. Often with overlapping nuclear loops. And the distinct Golgi zone is typically absent in these abnormal promyelocytes. So this is the normal promyelocyte showing Golgi zone, the pre-nuclear half, which is disappear or absent in the abnormal or leukemic promyelocyte. Cytoplasmic granules, while abundant in the classic hypersegmented form of the EPL, may differ in the appearance and often being coarser and dark than those seen in the normal promyelocyte, and slightly and usually obscure the nuclear details. The abnormal promyelocyte frequently contains numerous overlapping hour rods, and these cells that showing multiple hour rods can be called phagot cells. In the macro granular variant of APL, very few granules may be visible, like this case or this picture, and those granules present may be very fine. So this patient has APL, and patient with APL typically present with leukopenia and variable degree of anemia and thrombocytopenia. However, some cases can present with leukocytosis, especially in the micro variant or microgranular APL. It can be subdivided into two morphological features: hypergranular, which is typical, and hypogranular, a micro variant or variant APL. The neoplastic cells in the hypergranular typically contain numerous dense, dark purple granules and often obscuring the nucleus. And also it shows frequent hour rods, occasionally forming bundles, typically present and called phagot cells. And this is the common, in contrast, the hypogranular or microgranular variant. As the name implies, it displays spares to inconspicuous granules. APL is considered as one of the most emergency case in the unserious case in the hematology surface that need quick action because of high rate of death, mainly due to coagulopathy. So once you have a case, you suspect this is APL, just inform the clinician to give him a time to start the treatment as soon as possible. In addition to the CBC with differential and review of the peripheral blood smear, all patients with a presumptive APL diagnosis must undergo an urgent laboratory evaluation. And these evaluation or these investigation include coagulation panel or coagulation screen to evaluate the presence of DIC, flow cytometry and immunophenotyping, cytogenetic and molecular analysis to confirm the diagnosis and to confirm the presence of underlying BML-RARA translocation. Be careful. In case with markedly decreased white blood cells count, the abnormal promyelocyte are usually spares in the peripheral blood. Therefore, a careful morphologic evaluation of the peripheral blood smear with identification of abnormal problem is crucial. So this is why usually when you have a smear from the markedly decreased white blood cells, you have to go and find these cells in the thick area and also in the tail. Okay, so this chart would summarize all the possible quantitative disorders, starting with leukocytosis, which is divided into neutrophilia, eosinophilia, basophilia, monocytosis, and lymphocytosis. And this chart again shows the quantitative disorder, which is mainly in the leukopenia, so neutropenia, eosinophilia, basopenia, and monocytopenia and lymphopenia. So in the next slides, we will discuss some qualitative white blood cells with abnormal morphology. But before that, for the qualitative abnormality with normal morphology, but with the functional defect, the best example to be mentioned is chronic granulomatous disease, which is caused by a mutation in the NADPH oxidase gene, which leads to failure of neutrophil respiratory burst following phagocytosis. Okay, next, case number 6. So this peripheral blood smear is from a 30-year-old male presenting with systemic sclerosis. So his laboratory data shows mild leukopenia, almost normal red blood cells, hemoglobin, and platelet. So any guess the arrow cells? What is the arrow cell? Any guess in the Q&A? Let's have some interaction. Yes, so this neutrophil shows Pelger-Huet nucleus. So if we compare this nucleus with the normal, as we said, the segmented neutrophil shows segmented and more than 2 nuclear loop, but this cells shows only 2 loops. So neutrophils with 2 round nuclear loops connected by a distinct thin filament are designated as neutrophils with Pelger-Huet nucleus or nuclei, or as Pelger-Huet cells. So Pelger-Huet cells, Dr. Karl Pelger, a Dutch hematologist, was the first one who described this morphological feature in 1928. And the nuclear chromatin in the Pelger-Huet cells is generally denser than in the normal cells, as you can appreciate here. So it's denser. And this feature helps to differentiate the Pelger-Huet cells from the normal neutrophils and its precursor, which have more open or lightly staining chromatin. So neutrophil with identical nuclear feature can be seen in Pelger-Huet anomaly, which is autosomal dominant inherited disorder, which was described by pediatrician Chediak-Higashi in 1932, and occasionally observing the association with other clinical condition, including MDS, infection, and drugs also, where the proportion of affected cells in these situation is variable, but typically only a small subset are affected, which is clue since individual with true Pelger-Huet anomaly usually demonstrate these abnormalities in the majority of the neutrophils. When these cells are seen in outside of the context of the congenital abnormality, they are usually referred to as neutrophil with dysplastic nucleus or pseudo-Pelger-Huet cells. Okay, case 7. So this peripheral blood smear is from a 2-year-old boy who presented with delayed speech and skeletal deformities. His CBC shows normal white blood cell count. Patient is anemic and has mild thrombocytopenia. So any guess what these cells? No. Any other guess? Yes. So this is abnormal, large, coarse inclusions or granules that, this neutrophils showing large coarse inclusions that refer sometimes as Rayleigh bodies. That's true in the cytoplasm of the neutrophils. So if we compare it with the normal neutrophils, and this is neutrophils showing toxic changes. So it's more coarser and more darker. So this is Rayleigh bodies, which correlate or can be seen in the Alder-Reilly anomalies. So Alder's anomalies was first described by Alder in 1939 and by Reilly in 1941. Accordingly, it is known as Alder-Reilly anomaly. It is again autosomal recessive inherited disorder characterized by presence of large eosinophilic and basophilic granules in the cell of the myeloid and lymphocytic series. It can be associated with mucopolysaccharidosis, which is a group of metabolic disorder that caused by the absence or malfunctioning of lysosomal enzyme that needed to break down molecules called glycose aminoglycans. However, these cells should not be confused with the toxic granulation in the neutrophil, which are characteristically present in the background of, as we said before, in the background of sepsis, and can be seen in the background of infection or myeloid growth factor therapy. Okay, so this peripheral blood smear is from a 2-year-old girl who presented with fever, diarrhea, fatigue, and abdominal distension for the last 10 days. Skin examination was remarkable with patchy hypopigmentation around the face, trunk, back, abdomen, hands and feet, along with the hypopigmented silver gray hair. Her CBC shows leukopenia, anemia, and thrombocytopenia. So it's pancytopenia. And in this figure, the neutrophils reveal abnormal giant lysosomal granules, as you can appreciate here, which also can be seen in the granulocyte precursor, also in the lymphocyte and monocytes. So if we compare these cells with the normal neutrophils, so easily you can appreciate the difference between this abnormal finding with the normal neutrophils. So any guess what is this cell? True. So this is another example of the abnormal inclusion that can be observed in the lymphocytes. So as you, yes, most of the people, they mention Chediak-Higashi. Yes, so this is Chediak-Higashi syndrome. So Chediak-Higashi syndrome is a rare autosomal recessive condition that was initially described by Biggs Caesar in 1943 and Chediak in 1952 and Higashi in 1954. This rare autosomal recessive disorder arise from a mutation of less lysosomal trafficking regulator protein, which also called CHS1, Chediak-Higashi syndrome 1 gene, which leads to a decrease in the phagocytosis. Chediak-Higashi is characterized clinically by partial occlocutaneous albinism, which is reduced pigment in the skin and eye due to defect in the melanin granules, and also characterized by recurrent biogenic bacterial infection due to abnormalities in the granulocytes. Also bleeding. Neurological abnormality or neurological deficit are also common. So this disease, Chediak-Higashi, can be categorized into classic and atypical or mild forms. Individual with the atypical form may have fewer or less severe infection and milder symptoms. With children with the classic form of the disease are at the risk for developing the accelerated phase. The accelerated phase usually occur in up to 80% of the patient and can occur at any age. And accelerated phase is caused by an excess production of the lymphocyte by the immune system, and patient can develop symptoms such as fever, swelling of lymph node, or enlargement of the liver and spleen, also anemia, pancytopenia in general. And this is a serious condition and need to be treated right away. Gracile syndrome, also known as Chediak-Higashi-like syndrome, and is a rare inherited disorder that characterized by partial albinism and abnormalities of a platelet and abnormal of the platelet and white blood cells. The symptoms of Gracile syndrome and Chediak-Higashi almost similar, but on laboratory analysis, the white blood cells do not have the giant granules like those seen in the Chediak-Higashi syndrome. Therefore, the diagnoses are made differentially based on these white blood cells granules. Okay, case 10. So there is no case scenario. So what you can, any suggestion what this abnormal neutrophil called? May-Hegglin. Another suggestion, yes. So this neutrophil shows Dohly-like inclusion bodies along with large Dohly-like inclusion bodies along with large or giant platelet. That's true. This is, again, if we compare it with the normal neutrophils, as you can see, there is no any inclusions similar to this one. So this is May-Hegglin anomaly. So May-Hegglin anomaly will have Dohly-like inclusion bodies in the neutrophils, also in the eosinophils or basophils, as well as monocyte, thrombocytopenia, and giant platelet also can be seen in concurrent. The disorder was first described by Richard May, a German physician in 1909, and was subsequently described by Robert Hegglin, Swiss physician, in 1945. The May-Hegglin anomaly is inherited in autosomal dominant fashion owing to a mutation in myosin heavy chain 9. A May-Hegglin inclusion is due to aggregates of non-muscles myosin heavy chain 2A. Okay, case 11. This is a 50-year-old woman who presented with a 2-month of fever, chills, diarrhea, dry cough, and progressive dyspnea on exertion. Her CBC shows pancytopenia, and this is the peripheral blood. Any suggestion what you can see in the peripheral blood? Leishmania? No. Any other suggestion? Blue crystal? Okay. Malaria? No. Okay, so this figure it's showing leukocytes with or phagocytizing yeast form. So this yeast form is histoplasma capsulatum. So usually histoplasma, it will be engulfed by neutrophils or monocyte or histocytes. It's not like leishmania, which is more often extracellular, not like histoplasma. Histoplasma more often intracellular. So this infection is reported to be present in 5 to 20%, I guess, of AIDS patient, and 95% of the cases it is manifested in its disseminated forms. serum antibody and or antigen research can make a diagnosis, but the demonstration of the agent by culture or histopathological examination remains the gold standard method. So remember, histoplasm usually intracellular inclusions, and this is fungal infection, but this is picture. Any guess? No? So this is abnormal invasion, and it's distributed also extracellular in addition to intracellular. So this is leishmania inside and outside of the macrophage, characterized by kinetoblast and characteristic double dot appearance. So leishmania usually distributed intracellular and extracellular of the cells. Okay, other findings that you can see it in the white blood cells. So any guess? What are these findings? Yes, this is peripheral blood film from SLE patient. True. Yes, this is LE cells. That's correct. So this is engulfed material, usually coated by antibodies as LE bodies, and then ingested by viable neutrophil. And as you can see here, the nucleus of the neutrophils is pushed to periphery. So LE cells is an in vitro phenomenon, rarely found in vivo. Anticoagulant blood is agitated inside the tube by unknown mechanism, so that nucleus are released from the disrupted leukocyte, and the other neutrophil will ingest this this body, which call it LE body. Again, this LE cell is characteristic of SLE. Okay, this smear, any guess what is these cells? What are these cells? Yes, this case from CLL, but what I mean these cells, what you call these cells, not the viable lymphocyte, these cells. Yes, I'm receiving some, yeah. True. So this is smudge cells. This is high power of these smudge cells, so also known as basket cells. And these cells are ruptured white blood cells, leaving their nucleus to be free, and they can be pathologic and non-pathologic. A non-pathologic cause may occur during the smearing process. So smudge cells are produced if there is heavy pressure on the spreading slide, and a pathological causes of smudge cells may be due to leukemia, and in the lab, an albumin preparation can be used when many basket cells are present for cellular preservation in order to identify these cells. Okay. Okay. What is these cells? It's simple. Any guess? Hypersegmented neutrophil. Yes. So this is hypersegmented neutrophil. Remember, the normal neutrophils have an average of 3 loops and always fewer than 5 loops. So hypersegmentation or hypersegmented neutrophils usually seen in the megaloblastic anemia, and it considers sometimes as a dysplastic feature if it's combined with the other dysplastic morphological finding. I think this is my last slide. Thank you for your attendance. So now I can open the window for any questions. So there is one question, how we can differentiate between LE cells and hemophagocytic cells. Usually in hemophagocytic cells, you can see the monocytes or the histocytes engulfing the other viable cells like neutrophils or RBCs or nucleated red blood cells and the platelet. And hemophagocytosis mainly observed in the bone marrow more than in the peripheral blood. But in the LE cells, it's large red inclusions, and it's only one inclusion, and it's inside the neutrophils, pushing the loops of the neutrophils in at the periphery. So it's easy to be differentiated. That's true. This is another question. Can smudge cells occurs due to wrong way of making the blood smear? Yes, it can be because all time when we prepare the smear, we prepare it manually. But right now, we reduce this artifact by using the machine. But true, if we want to prepare and we apply more pressure, we can produce more smudge cells. Yes, what are the dysplastic changes in the white blood cells? There is a lot of dysplastic changes, and I will leave this question to my colleague, Dr. Nahla, tomorrow, but because I believe she will discuss some cases for MDS. So now benign, I discussed only the benign white blood cell disorder, and I believe, I'm sure Dr. Nahla, she will go through these features in details. طيب, next question. Yeah, can you show more slide regarding leishmania? The important thing regarding leishmania, it is extra and intracellular inclusions. So, and it's smaller than the other inclusion. When we compare it, for example, the histoplasma, see, histoplasma, it's large, round, dark inclusions. This is why it's called capsulatum. So it's easily can be differentiated from the small inclusions that distributed extra and intracellular. And this is what we call it kinetoblast, and usually it's characterized by double dot appearance, not like the histoplasma. Okay, what other question? This is good example. What is the source of our roads and from where it is coming? So our road is the abnormal collection of the of the primary and secondary granules in the blast. So there is a lot of when you have a leukemia process, so these cells behave abnormally and in crazy ways. So these are abnormal collection of the granules, mainly primary and secondary together. So this is how our rods is formed. Smudge cells could be of any type of cells, mainly lymphocyte, but yes, it can be any type of the cells. Sometimes you will find some ruptured neutrophils and eosinophils and basophils with the same process. Okay. Next question, can you please yes, I think Dr. Muhammad al-Muhammadi, he went through this question yesterday. Can you please describe the difference between thin and thick film for malaria? So usually thick film, it used to identify if there is malaria or not. And the thin film is usually used to identify the species. So this is the main issue. So first you will go through thick film just to identify if there is malaria. Then after thick film it's positive for malaria, then you will go to the thin film to identify what kind of species that you have it in the thin film. Recording, I think, from the SSPD website. Can show our rods seen in mature cells? Yes. Our rods, be careful when you deal with the APL, and the main treatment for the APL is ATRA, which make these neoplastic or abnormal promyelocyte to start differentiated. So if you don't give another chemo to kill these cells, of course, some of these cells, when start differentiated, it can reach to a level or the stage of neutrophils, and still there is our rods. And in the follow-up bone marrow, please be careful when you examine the follow-up bone marrow or peripheral blood for the patient who diagnosed with APL. Don't don't just wait and examine or look for the promyelocyte. No, also examine the neutrophil very carefully, because sometimes there will be abnormal neutrophils still keeping some faint our rods. Okay. If we have our rods in the neutrophils, do we consider it as a part of dysplasia? And I will consider this as a part of residual disease, okay? Especially in the background. So the our rods, you will never see the our rods in the other context other than the acute leukemia. However, some very rare findings shows lymphocytes with the our rod like inclusion, but it doesn't not related to the leukemia process. Okay, how we can differentiate between monocyte and reactive lymphocyte? As I said earlier, monocyte is larger cells, and usually shows vacuolation, and blue-gray cytoplasm with indented nucleus. But the reactive lymphocyte, it's size-wise, it's smaller than monocyte, and the NC ratio is high, showing scant little cytoplasm, dark blue with very condensed chromatin, and inconspicuous nuclei. If we compare it with the monocyte, the chromatin is more open if we compare it with the lymphocyte. And also one of the key features that I tell my colleague, always look to the other cells to compare the normal cells with one that you are examined. So if you have atypical lymphocytes, you can compare it with the other normal lymphocyte in the same field or in the same peripheral blood smear. Okay, is there any? I think this is the microscope out and depend on the good new machine that prepares slide and send it electronically to doctor and clinician together with the everyone. That yes. Regarding this question with this microscope out on dependent, yes. So nowadays there is era of technology. There is something called the digital pathology. So they can use artificial intelligence technology. So computer can recognize these cells by giving all the picture and a million of the picture of the different variant and different shape of the cells, and the computer start to recognize these cells and memorize these morphology and start identifying the cells. So it's very advanced technology, and some center in US and Korea start using this artificial intelligence in the lab, and hopefully one day we can use it also in our laboratory. Okay, reactive lymphocyte. As I said, reactive lymphocytes mean lymphocyte showing or start showing some variation or alteration in the morphology that not similar to the normal one or the typical classical one, because the classical lymphocyte is small cells, double size of the RBCs, condensed chromatin, high NC ratio. But the reactive one starts showing some changes in the morphology by showing some abundant cytoplasm. The color of the cytoplasm start become more darker compared to the normal, the classical one. But the morphology of the nucleus is still the same, condensed chromatin, inconspicuous nuclei, because whenever you find the chromatin is opened or fine with clear nuclei, so that means this is immature form of the lymphocyte, can be pro-lymphocyte or can be blast. So this is how we can differentiate. And always, as I said, compare the cells that you are, or the suspicious cells with the other cells in the same field or in the same slide, because lymphoma cells usually shows monotonous morphology. However, reactive lymphocyte shows variation of morphology. This is not 100%, but generally in most of the cases. Okay, next question. Yeah, this is good question. Why white blood cells qualitative and quantitative abnormalities in the COVID patient? So COVID patient usually presented with severe lymphopenia and severe lymphopenia, and the morphology of the lymphocyte in the COVID patient, it's really atypical, and and shows a very abnormal morphology, but not in the level of blast. Yani you cannot confuse yourself, or you become confused. This is blast. No, this is mature lymphocyte, but it's very abnormal, atypical due to the infection. But usually COVID patient, they presented with the severe lymphocytes. So sometimes it's difficult to find good number of lymphocyte to give a good morphological assessment. IM slide. Okay. Some question I couldn't understand what exactly you mean, but let me go through other question. So yes, what is difference between reactive lymphocyte and atypical lymphocyte? So in the older day, the word of the reactive is similar as atypical, especially in the hematological field. But the atypical in the anatomical pathology, it's more likely to be abnormal or neoplastic. But in the hematology, atypical, it's more likely to be reactive. This is why in the report, some people or some pathologists, they use reactive / atypical lymphocyte rather than using only atypical only, because it will make the clinician a little bit confused. So, and I prefer, if you want to use reactive alone, it's fine. If you want to use atypical also, just put reactive or atypical / reactive lymphocyte. But if you want to say this is abnormal lymphocyte, you can say atypical or abnormal atypical lymphocyte. Okay, in case of platelet aggregation, it shows wide. Yeah, oncology one. We are, as a clinician in hematology and oncology, want the slide in system, same as radiology picture. And I think this is something like, again, under the digital pathology and the artificial intelligence. So hopefully in the future, we can reach this point to upload all the morphology in the system. How common to see lymphoplasmacytic cells in the COVID patient? Not sometimes, yes, because lymphoplasmacytoid cells, it's a kind of morphological alteration in the lymphocyte that correlate with the infection, especially in the viral infection. So again, COVID patient usually presented with lymphopenia, so it's hard to find a good number of lymphocytes to go through them and to examine their morphology thoroughly. Yes, is there any case slide for infectious monoclonal? The case that I showed in my presentation, it's from the patient who has infectious mononucleosis. Okay, next question. What is the significance of finding toxic granulation in normal, not septic individual? Usually the toxic granulation, it's mainly correlate with the infection and inflammatory process, and the degree of the increased granulation and how much it's dense and darker, it's also correlate with how the patient correlate with the viral load or the bacterial load in the body. So in the normal person, it's obviously you should not to see neutrophil with the toxic granulation, but sometimes the staining process may make these neutrophils to show their granules more darker, and it can be false finding. It's not true finding. But in general, toxic granulation, you only see it in the reactive process. As I said, infection, inflammatory process, drug, secondary to paraneoplastic condition in some cancers. Okay. Dr. Faisal, and I will really I will meet with the head section and with the head to let them know about your idea to send all these pictures through the system. Don't worry. Yes. What the best area of the smear to detect cells inclusion? Again, the best area for of the peripheral blood examination is the body of the slides. So, but of course, if you find your answer and your evaluation is sufficient by reviewing the body of the slide, so no need to go to the tail or to the head of the slide. But if you have suspicious and there is clinical history of infection, especially parasites, so at this time you have to go to the peripheral, to the tail of the slide, and even to the head of the slide, just to pick up these parasite, because the parasite is heavy organism. So while when you smear the slide, it will keep either in the tail or in the head of the smear. And even when you reviewing the slide for patient with severe leukopenia, and you are suspecting, for example, leukemia, or you're suspecting abnormal cells, so go to the edges and go to the head of the cell, because again, while spreading, maybe these cells will distribute it or distributed in the edges of the slide, not in the body of the smear. Okay. Yes, white blood cells is usually normal with absolute lymphopenia in COVID patient. Yes, because sometimes COVID patient, you can see normal white blood cells with the normal neutrophils, or sometimes high number of neutrophils, but the main player in the COVID patient is the lymphocyte, which is reduced. So the absolute lymphopenia, it can be corrected by the increase of the other cell white blood cell subtype, like neutrophils, monocytes. Is there special care? Yes, we can. Yes, we can see increased granulation in patient using GCS, if that's true. This is why I said increased granulation. So toxic changes, it's a terminology that given for neutrophils that showing increased granulation, either due to infection or drugs like GCSF. But how we can use this word? We can correlate, always we correlate. So if you, while you're examining a peripheral blood and you see some neutrophils with the increased granulation, you can easily say this is neutrophils showing increased granulation or toxic granulation, likely due to GCSF or growth factor therapy effect. And again, always correlate with the clinical correlation. So patient, if he presented with infection, so it's mainly due to infection, but if there is no any signs or history of infection and inflammatory process, so again, you have to look after what the reason behind this. And usually in the GCSF, not all the cells shows increased granulation. And again, in GCSF, you will find some immature cells in addition to the neutrophils. Can we see toxic granulation in the hemolysis? Not usually. Again, toxic granulation mainly seen in the infection process, inflammatory malignancy, but in the hemolysis in particular, it's not a part of the hemolysis unless if the hemolyzed patient he also has infection or inflammatory process. Yes, any effect of the steroid drugs on the white blood cells. Usually steroids it increase the neutrophils, but in the morphology wise, it may show some little changes, but not that much, and not in the level of the true dysplasia. You can find some abnormal or atypical morphology, but I don't think it exceed 3% of the neutrophils or maybe 5%. This is why when we reporting the dysplasia, usually we use a number of involved cells. So usually based on the WHO, any dysplasia above 10% it considered significant. But if you have a dysplasia less than 10% or less than 5%, so based on the WHO, any dysplasia more than 10%, it's significant. However, if there is cases shows 5 to 10% dysplasia, again, you have to correlate these findings with the clinical presentation, with the clinical background, with other lineage, start to see if the patient has abnormal blast or abnormal cells. But if it's less than 3%, it can be seen in any condition, so it's not that much significant. Okay, next. Yes, in the eosinophilia, this is what I said. Usually there is a big list of conditions and disease that cause eosinophilia. So this is why any patient who presented with eosinophilia just exclude the secondary causes before we jump to the primary causes. And again, sometimes patient with severe allergic reaction can show eosinophils more than 30%. But again, this is what I said, there is short-lived eosinophilia and prolonged eosinophilia. So prolonged eosinophilia, based on the WHO, it's defined as more than 3 to 6 months. So this is prolonged persistent eosinophilia that need more investigation. But eosinophilia that associated with parasite or severe allergic reaction, it's usually short-lived. It can be disappear after you treat the primary cause. Okay, so thank you for your attending. So we just have extra 4 minutes. So hopefully I give you simple to the point white blood, non-malignant white blood cells finding. So hopefully we can continue these courses in the future, and inshallah tomorrow we'll continue this activity with Dr. Nahla. Shukran jazeelan.